The next speaker is Natalie Allen, I just spotted over there. Natalie is a physio and an academic at the University of Sydney, and her research focuses primarily on exercise interventions aimed at helping people with Parkinson's disease to live well, and by optimizing movement, reducing falls, and managing pain. So please join me in welcoming Natalie.
Thank you, Kim, for that introduction, and a thank you to the organisers for inviting me to come and speak today. And before I get started, I also want to acknowledge the people that have made this work possible. So our funding from Parkinson's New South Wales and the University of Sydney, all the people that have contributed to this research, many of whom are in the room today and are too many to list on the slide, as well as the people who've participated in our work. So we know that people with Parkinson's disease are twice as likely to fall as people in the general older population. And of those who do fall, about 60% of them will fall multiple times in a year, and I'm sure clinically we've all met people with Parkinson's who fall on a daily basis. So what I'm going to do today is first of all have a look at a Cochrane review that we published a couple of years ago that explored interventions for preventing falls in Parkinson's disease. Have an overview of the results of that, which will lead into presenting the results of a study that we've just finished, which looked at a multi-domain fall prevention intervention for people with Parkinson's. So the main aim of the Cochrane review was to assess the effects of interventions designed to reduce falls in people with Parkinson's disease. And today I'm just going to talk about the exercise interventions, and that's where most of the evidence was. So the studies that we included were randomised control trials that aimed to reduce falls, and they had to report either the rate of falls or the number of people who fell. So we used standard Cochrane procedures, we searched 7 databases up until October 2021, and we used the grade approach to rate the certainty of the evidence. So if we just focus on the studies that looked at exercise compared to a control intervention, there were 12 studies, and most of the interventions could be categorised as gait, balance and functional training, and that included Parkinson's disease-specific exercise, so things like queuing. There were also 2 interventions that used resistance training and 2 interventions that used 3D exercise, so Tai Chi or dance. The duration and the dose of the interventions was really variable, and so the durations lasted between 6 and 26 weeks. But notably, all the included participants had mild to moderate Parkinson's disease and good cognition, and the studies would exclude people with a mini mental state score of less than 24. So this is the main forest plot from the review comparing exercise with a control intervention, and it shows that exercise can reduce falls in some people with Parkinson's disease. So you can see there the effect size overall was favouring exercise, and it was reducing the rate of falls by about 26%. And a similar story with the number of fallers, where it was reducing the number of people who fell by about 10%. But you'll notice on both of these plots the little grade certainty symbol up the top, and that's showing that we downgraded the certainty of this evidence to moderate. And the reason for that was because people with cognitive impairment were excluded from these studies, and the studies also focused on people with mild to moderate disease. And that's a problem because clinically speaking, we see a lot of people with Parkinson's who have impaired cognition who are falling regularly. We know that cognitive impairment actually is very common as the disease progresses. So that means a lot of the people that we're seeing clinically had been excluded from these research trials, so we don't know if this evidence applies to them. So what we wanted to do was explore whether there was anything in the evidence that might indicate whether or not disease severity made a difference to the outcome. And we were unable to do your usual subgroup analysis because the studies had included people with a spectrum of mild to moderate disease. But what we did find was there was just a few studies that had reported subgroup data based on disease severity. So we were able to pull subgroup data. So what we've got here is that pooling of subgroup data for the rate of falls. There's only 2 included trials. The trials were both big, high-quality trials, and they trialled minimally supervised exercise that was home-based. But what you can clearly see here is that up the top there we have the higher disease severity participants, and following this exercise intervention, the effect is actually favouring the control group, showing that for the higher disease severity participants, they were having an increase in their rate of falls following exercise, whereas the lower disease severity participants down the bottom were the ones that were benefiting and having a reduction in the rate of falls following exercise. So we think we need to be careful with this finding. We're not saying that if you have people with more advanced Parkinson's disease that we should not be prescribing exercise for them. Exercise is important for everybody, but I think it does mean we need to be really careful and think really hard about how we set up that exercise, how it's supervised, and what other fall prevention strategies we should be putting into place for people with more advanced Parkinson's disease. So the key points from the Cochrane review findings then are that fall rates are high even after effective exercise interventions, like we saw Sally point out earlier. Minimally supervised exercise is pragmatic and sustainable, but it doesn't reduce falls in people with more severe disease. And most people with Parkinson's develop cognitive impairment, but typically they've been excluded from the fall prevention research. So that led our research team to think that we needed to think further about what fall prevention could look like for people with Parkinson's disease. So we developed a multi-domain intervention, which was specifically designed to include people with more severe disease and cognitive impairment, and we called it the Integrate program. The program included home fall hazard reduction, exercise, and what we've called safer mobility behaviours, and it was tailored to the individuals and targeted people's specific impairments and mobility limitations. So the Integrate program started out as it was going to be a randomised control trial, but then COVID came along, as did for many people, and it ended up having to be a single group study. So the primary outcome then was feasibility and acceptability of the study, of the intervention, and we did still measure effectiveness in order to get a little bit of an indication as to whether there was a signal of effectiveness or not. So we tried to make sure that we targeted the study at people with more advanced disease. So people had to have fallen at least twice in the prior 6 months, but they still had to be able to walk at least 10 metres with or without a walking aid. We included people who had substantial cognitive impairment, provided they had a willing and able care partner who could help them to engage with the program and help to supervise their exercise. The intervention was all home-based, and it very much took a collaborative approach. So the participants worked with experienced therapists, and those therapists worked with the participants and their care partners and involved them actively in goal setting and in shared problem solving and working out the specifics of what the intervention would look like. People had 8 to 12 home visits depending on need and were supported by phone calls in between those home visits. And they were also encouraged to continue with the intervention beyond the 6-month mark. The first thing that the OT did at their first home visit was assess people's functional cognition, and they did that using the large Allen's cognitive level screen, which uses the lacing tool and the placemat. And the reason why they did that was then they could report back to the team about the person's functional cognition to help us to tailor the intervention to the individual in a way that they could meaningfully engage with it. The OT also looked after the home fall hazard reduction component of the intervention, and everybody got individualised recommendations. And the physios worked on the exercise component of the intervention. So again, the exercise was individualised and progressed for each person, but had to focus on balance, leg muscle weakness, and when required, also freezing of gait. And care partners were actively involved with this as well. So most of the exercise sessions were done by the people with Parkinson's at home without the therapist present, but the care partners were trained into how to safely supervise and assist with that exercise, and could also talk talk to the therapist on the phone and things in between visits if they were having problems. So it was carefully prescribed and monitored, but the physio was not there every time. And then the third part of the intervention was looking at safer mobility behaviour training strategies. And so by this, the physio and OT worked together and looked at the way the person was moving around in their home environment and worked out ways that they might be able to do that more safely. So a couple of just simple examples are getting people to slow down and concentrate, or pausing to get their balance between standing up and walking. And these sorts of strategies were reinforced by things like signs, notes, mantras, or reminders from care partners. And if you're interested in that concept, my PhD student Daniel is presenting a scoping review looking at this idea this afternoon. For the outcome measures, for feasibility, we looked at recruitment and retention rate, as well as adherence and adverse events, and we interviewed people to explore acceptability of the intervention. And to get an indication of whether there was any effectiveness, we used a number of measures. I won't go into all of them, but just these three I'll mention today. The goal attainment scale, where people set a goal related to safer mobility at the initial assessment that we re-evaluated after 6 months. We also measured the short physical performance battery, which is a composite measure of standing balance, walking speed and sit to stand time. And we measured falls using falls diaries and monthly phone calls for 14 months. So 2 months at baseline, the 6-month intervention period and the 6-month follow-up period. And we found that the intervention was feasible. We had 29 participants who had moderate to moderately advanced Parkinson's and mild to moderate cognitive impairment. They were falling frequently, with a median of 12 falls per person in the prior year. The recruitment rate was 49%. We had 3 people dropped out over the 6 months for reasons unrelated to the intervention. And nobody reported any adverse events while undertaking the intervention, so nobody had any falls that were experienced while they were doing intervention-related activities. Overall, we had good adherence. So with the home fall hazard reduction, 90% of recommendations were either fully or partially completed. The exercise had a really broad range of adherence, like exercise studies often do. But on average, 97% of prescribed sessions were completed. And with the safer mobility strategies, people reported remembering to use their strategies about 68% of the time, and ranked that as a habit score of 3.5 out of 5, where 1 was no habit at all and 5 was a well-established habit. The intervention was also acceptable. So we analysed interviews from 16 of the participants, and we found 4 themes. So they were an appreciation that it was a home-based and individually tailored program. People talked about the benefits of that collaboration and shared decision-making, and that they had an increased awareness of safety, and that having the program gave them a purpose that helped to drive change. In the interest of time, I won't go through quotes for all of those themes, but I just wanted to show you this one quote because I think it gives a good flavour of the sorts of things people said. So this participant said, "Having someone come in to look at the home is useful because it mirrors the same activities and environment I have to deal with every day." So I think that just shows if we can do home visits, it's really beneficial. In terms of whether it was effective, it's a 29-person small single group study. So this is just to get an indication, but the results are promising. So 81% of people achieved or exceeded their safer mobility goal. 19% didn't meet the goal, but nobody deteriorated in relation to their goal. The group also overall improved on the short physical performance battery with a mean change of just over 1, which is likely to be clinically meaningful. And overall, it looks like we were maybe helping to reduce the rate of falls. So it's a small study, but people were falling a lot. So there was an average of 32 falls per person during the 6-month intervention period, but that reduced to 17 falls per person during the 6-month follow-up period. And if we have a look at what that looks like graphically, the orange is the 6-month intervention period and the grey is the 6-month follow-up period. And you can see in terms of people who had no falls, we increased from 2 with no falls in the intervention to 4 with no falls in the follow-up. But where I think we really made the biggest difference was at the other end of the spectrum. So during the intervention period, we had 4 people who fell between 51 and 199 times, but we had nobody who fell any more than 45 times in the follow-up period. So it seems that we maybe are making a difference there. We did go ahead and calculate an incident rate ratio, even though it's only got 29 people in the study. And we got a 49% reduction in fall rate in that follow-up period. So close to Sally's 50% goal, but it's a small single group study, so I won't retire just yet. So the key points from this are that people with frequent falls and mild to moderately impaired cognition were able to safely engage in this multi-domain program with support from care partners. Most met or exceeded their safer mobility goal, and there was an improvement in overall mobility, and it looks like we reduced falls in the follow-up period. So in terms of future direction, I think this Cochrane review result and the Integrate pilot study combined is pointing towards the fact that we need to have some large-scale RCTs looking at multi-domain or multifactorial interventions for people with Parkinson's across the disease spectrum, because they are at high risk of falls, and including people with more advanced disease. And I just also wanted to finish up with the last couple of minutes also looking at the World Guidelines recommendations for people with Parkinson's as a bit of a practical takeaway, and to put those guidelines in the context of what we've just seen from the review and the Integrate study. So in the guidelines, there's a strong recommendation for people with early to mid-stage Parkinson's and mild or no cognitive impairment to be offered individualised exercise programs that include balance and resistance training, and that this can be combined with general mobility and ADL rehabilitation. And I think this recommendation is really borne out in the Cochrane review, where we saw that following exercise that's designed to reduce falls, that there was a 26% reduction in falls in people with mild to moderate disease without cognitive impairment. There was also a recommendation that people with more advanced disease should be offered exercise training targeting balance and strength if supervision by a physiotherapist or other suitably qualified person is available. And I think that that guideline recommendation very much came from those studies such as PD Safe and PD Fit that we pulled together in the Cochrane review that showed those with more advanced disease were actually having an increased rate of falls following the intervention. But I think the Integrate study I just presented also is food for thought about what supervision by a physio or other suitably qualified person needs to look like. Certainly in the Integrate study, we had highly experienced therapists who were prescribing and closely monitoring the exercise, and who were teaching the care partners to be able to assist and supervise that exercise. So I think in terms of exercise being sustainable at an appropriate dose, we need to be thinking about where we can provide that to people. And the final weak recommendation in the guidelines was to offer multi-domain interventions, so things like what we've just done in the Integrate study. And the reason why that's a weak recommendation is because in Parkinson's disease, we just simply don't have the evidence about whether this is effective. There hasn't been an RCT that's just looked at home hazard reduction, for example, in Parkinson's disease. So this is where we think we need to go to next, and we're hoping that with the results from the Integrate pilot study that we might have some good evidence to put together towards applying for a large-scale RCT to look at this sort of thing. Thank you.
Thanks, Natalie. We've got time for one question. Anyone with a burning question? Yep, Sally.
Thanks, Natalie. That was a great presentation. I just wondered how you were thinking that you would tackle this question about multifactorial interventions in some new studies. Had you thought about how you would design a study to look at that?
Yeah, so I mean, at the moment, the Integrate study was a multi-domain intervention. So we took those 3 components. We did tailor them individually, but everybody did receive those 3 components. What we haven't trialled in a feasibility study at the moment is doing something that's truly multifactorial, where perhaps you measure risk factors more broadly and then tailor to those different risk factors so that different people get different types of interventions. But I think with people with Parkinson's disease, that they're obviously at very high risk of falling, and that would be a good thing to do. There's so many things you could look at around medications and nutrition and things like that with these people as well. Yeah.
You could use the factorial design to layer interventions, so you can start to look at how the different intervention components might work independently and together. Yeah. It would be a bit complicated, but yeah, interesting.
Maybe I'll have to look up your email address, Sally.
Well, actually, just ask one question from Slido as well. Are there any studies that have trialled PD Warrior?
Not that I'm aware of. So PD Warrior is designed based on evidence. So the PD Warrior looks like a very fun and engaging program that has looked at the evidence and has designed their exercise intervention based on that. But I'm not aware of any studies that have actually trialled it, say, in an RCT. But I think Melissa's presenting this afternoon, so she might have some more to say.
Thank you. Thank you very much.
Thank you so much.
Great talk. Well, this was the conclusion of another great session.